Hello, and welcome to April Grand Rounds. We are absolutely delighted to have both people here in the room and people on Zoom. And I do want to start with a land acknowledgement. We acknowledge we are on the traditional land of the first people of Seattle, the Duwamish people. And we want to honor the Duwamish people, past and present, with gratitude, and also the land itself. We acknowledge that this does not take the place of authentic relationships with Indigenous communities, but does serve as one way to honor the land we are on and to resist cultural erasure. We also acknowledge that this country exists and prospered as a result of free enslaved labor of Black people, and we honor the legacy that the African diaspora and Black life, knowledge, and skills is, and which was stolen due to violence and systemic oppression. And as we do every Grand Rounds, we affirm our commitment to be aware of our own privilege and of oppression and how those play a role in the lives of our patients, families, and employees as we strive to be anti-racist and improve care for those with less privilege. I also want to celebrate April is Autism Acceptance Month, and we have some pictures of some of the autism locations here at Seattle Children's, and are very excited to be able to have coordinated having an autism focus for our Grand Rounds today. And in order to introduce our speakers today, who we're very excited about, I'm going to introduce Dr. Mendy Minharis, clinical psychologist and executive director of the Seattle Children's Autism Center.
Good morning, everybody. Thank you, Carol. So yes, I have the great privilege of introducing two dearly beloved friends of mine and longstanding colleagues to you guys this morning. I think people who know me know that I often speak off the cuff, but when it's really important and my words have to really be precise to honor people, I have to write it down. So I will start by just saying a few words about my relationship with our two speakers today, because it's very fun for me to have them here. I've known them for a very long time. And then I will give you a bit of bio on them. So Grace John Gu, well, I don't know who's going first, but I was gonna say our first speaker, but one of our speakers, okay, our second speaker today. Grace and I have known each other since we were in graduate school and during our doctoral program at University of California, Santa Barbara. And Antonio and I met when I joined the faculty at Stanford at the same time that he joined the faculty at Stanford. And at the time we were actually the autism program at Stanford, the two of us. I think it's gone from like 2 to 5 maybe. So you guys have more than doubled in size, which is excellent. But an amazing amount of work is coming out of the team at Stanford. And so that's what we're really excited to hear about today. So maybe a little couple of funny anecdotes. One is, Grace and I actually only overlapped 1 year in graduate school, but we have been on the same exact pathway for about 25 years. We went to the same undergraduate institution. We overlapped in grad school for 1 year. We did the same internship. We did the same postdoc. And when I left Stanford, Grace was the next clinical psychologist that arrived. So the good news about that is Grace will be arriving in Seattle soon. I'm sure of it. I'm positive that this must happen. And luckily she won't leave Stanford without Antonio. So I'm anticipating that they are both going to come. Antonio, I really owe a debt of gratitude to as a mentor. When I arrived at Stanford, Antonio was new faculty at Stanford, but a well-established, faculty member. And I was brand new faculty fresh out of my postdoc. And I really definitely, had a phase there of some really excellent mentorship in grant writing, in how to meet a last minute deadline, in how to fit a grant onto, the required number of pages. But those were some really seminal years for me that really, set the stage for a lot of the work that I still do today. And I definitely owe Antonio for some of those formative, mentorship years, which I really greatly appreciate. So let me give you guys a little bit of info on their accomplishments. We're going to hear from two very accomplished folks, and then we'll get down to hearing their remarks, so I don't take up all their time. So I think we have some titles up here. As you can see, Antonio is a professor of psychiatry and behavioral sciences at Stanford. He is the director of the Child and Adolescent Psychiatry Division and the Autism and Developmental Disorders Clinic at Stanford Medicine, and I guess you guys call it Stanford Medicine Children's Health now. That's not what it was called when I was there. And he has more than 20 years of experience assessing and treating children with autism and developmental disorders. His research, which we'll hear about today, I'm really interested to hear some of these updates, is in the neurobiology of ASD and the development of innovative treatment for individuals with neurodevelopmental disorders. He has been the principal investigator on a number of trials, on a wide range of interventions, some of which I'm not going to say because I can't pronounce them, but there are quite a few compounds that he has researched, things like N-acetylcysteine. That's one I do know how to pronounce. We'll get the rest from him as he goes into his talk. And he's the developer of two new instruments, which I'm hoping you're going to tell us about today, because I'm very interested in this. The Stanford Social Dimension Scale and the Dimensional Assessment of Restricted and Repetitive Behaviors. So I think that will be very exciting to hear about. And Dr. Harden has published more than 150 journal articles. That explains what he does at midnight when he's not sleeping and still sending emails and working. And he's co-authored several book chapters in the field of ASD. Dr. Zhang Gu is a clinical psychologist and a BCBA D, and she is a clinical professor and the director of the Autism Intervention Clinic, as well as the well-being director. We need to have you back for a talk on that, I think, within Stanford University's Department of Psychiatry and Behavioral Sciences. Dr. Zhang Gu is a licensed psychologist with expertise in training parents to promote healthy development of social skills in children and managing challenging behavior using positive behavioral approaches. So we're going to get a balanced research update today, some pharmacological and assessment research, as well as some behavioral intervention research. Dr. Zhang Gu has published in peer-reviewed journals and written book chapters on autism, and she specializes in pivotal response treatment. So I imagine we'll be hearing quite a bit about that today, having completed her doctoral studies under the guidance of Drs. Bob and Lynn Cagle. Grace, let's see, she oversees the PRT program at Stanford. She serves as the associate editor for the Journal of Positive Behavioral Interventions, and she's written a book on professional well-being. So if you're interested in that part of her work, you can go look up her book. So without any further ado, I bring you, it sounds like Antonio first, Dr. Harden first, and then Dr. Zhang Gu.
Thank you, Mandy, for the nice introduction. And thank you for the invitation here. I think Grace and I were honored to be here to talk about our work. So Mandy gave me the bug of PRT. And since then, we've published quite a bit on this area. As a child psychiatrist, I knew not much about early behavioral intervention, and now I look a little bit smarter when I talk about PRT, but I still need some coaching, so that's why I have Grace with me here today. So we're going to tell you a little bit about what we've been doing at the Autism Center. It's not as big as an Autism Center as you have here, but we're more than 5 people now, so we have expanded and we're aiming to be a much bigger place, and hopefully one day we'll get our own physical location. First thing first, in terms of some disclosures, there are some suspicious relationship there, but you don't have to worry about them. I will not be mentioning anything about them. And some disclosure is that I will be mentioning some off-label use of some medications. I will be discussing that. So these are the learning objectives. We'll talk a little bit about challenges of multiple delivery models, evaluate the benefits, the beneficial effects of parent training, and we'll talk about the challenges in designing clinical trials. I felt it will be too boring to talk about clinical trials and how to design them, so we're including some more clinical data to allow people to not to take a nap as early as this morning. So this is the outline. We'll talk a little bit about the costly journey. We're here, but we've paid some price to be here to learn some insight. We'll talk about the challenges that we face in autism, but also in other neuropsychiatric disorders. We'll talk about outcome measures in terms of why we have to have better outcome measures. I started in neuroimaging. I moved to clinical trial when I went to Stanford, but most recently I've been more focusing on development of clinical measures because I feel that are very important to develop very good measures that with good psychometric properties. And Grace will cover approaches to early intervention, and we'll finish with summary and conclusion. Autism, I hope that you're all familiar with the definition, but in case we have students, graduate students who are not involved in the field of autism. So to be able to make the diagnosis of autism, you have to have deficits in two major domains. One is in social communication and social interaction, and the other one is in restricted repetitive behaviors. When you're thinking about deficits in social communication, you think of deficits in social emotional reciprocity, abnormal social approach, reduced sharing of interests. So that's one domain. The other domain is deficits in nonverbal communication, the use of gestures, body language, good eye contact. And the third domain is deficits in developing and maintaining relationships. We know we work with a lot of kids who have reasonable relationship with older kids or with younger kids. They sometimes might not be very appropriate. So that's why we have to think about the context of these relationships. The second domain is restricted repetitive patterns of behaviors, interests, and activities. And there are four different subdomains here. The one that's new for the DSM-5, and we all welcome this addition, which is the presence of hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of environments. There's also stereotyped or repetitive speech. There is insistent on sameness, and there's restricted fixated interests that are abnormal either in intensity or focus. And I have three pictures here of some restricted interest. The first one on the left-hand side, at the bottom here, this is an electrical circuit. This is a 7 or 8 year old. I don't know, Mandy, if you remember, I saw him back then. And I have no idea, I don't know about that, but this is a functional electrical circuit. And this kid had this narrow interest. And as he getting older, the complexity of this electrical circuit will increase. So that's what we call like a restricted interest that is unusual in its intensity. The second picture here is the labels that a kid, a 19-year-old, will collect and will make sure that they are in the same place in his room. And if they move a little bit when he goes to school, he will throw a major tantrum when he comes back. The picture here at the top, it's lining up of objects. That's a common behavior we see with kids. But I can tell you these airplanes were not lined up by a kid on the spectrum. They were lined up by my kids who definitely have some form of psychopathology that has to be determined, but it's not autism. And this is to show that a cigar sometimes is a cigar, and we want to be mindful of that and not to look at the overall picture that we are seeing in front of us. The epidemiology, 20 plus years ago, the prevalence rate were much lower than now. And when we talked about autism, it was 20 per 10,000. And if you put all the autism spectrum disorder, we're like around 40 to 60 per 10,000. But with the recent CDC reports, like the numbers keep increasing. And the most recent one in 2022 is 1 out of 36. I joke and I say it's like the stock markets, but it's a bullish market. It's been going up for a while. So that's why we have to think a little bit about why we're having these numbers. And when you look at individuals who are able and on the high functioning spectrum, like the percentage increase from 30% up to 70%. And about 25 years ago, it's actually the opposite, which is 70% of the individual were profound autism, minimally verbal. Now it's the opposite. So the question is that there is an increase in recognition, increase in incidence, or overdiagnosis. And this by itself, we can spend like a whole day or like 3-4 days to talk about that. But it's important to mention it here in the context of this grand round. And the summary is all of the above. And we'll give you some information. There is definitely a shift in the diagnosis, a broader classification, increase in the identification of individuals with mild symptomatology. I remember a patient that I saw when I was working in a community mental health center. I reviewed the chart. It was an individual with schizophrenia, the 27-year-old individual with schizophrenia. Within 5 minutes of me interacting with this individual, I was almost 100% sure that this individual had autism, but because he was verbal and able to interact, people before who saw him before me did not think of autism. And also there is a recognition of a feature individual with low level of cognitive functioning. When we think about increase in incidence, the actual number, like one example comes to mind, which is prematurity. 30 years ago, or 40 years ago, when you had a child who was born at 1.1 pounds, 1.2 pounds, it's unlikely that this individual will survive. Right now, we're seeing people who are surviving with like 1.1 pounds, 1.2 pounds. Not all of them will develop autism, but a small number will end up developing autism, and that could be contributing to the increase in the actual number of individuals with autism. The last one I want to touch is the overdiagnosis. This is a great editorial by Eric Combone. I recommend everyone to review it and read it. It gives you a different perspective why there is an overdiagnosis. And if you talk to people around the country, the percentages varies, but with regard to individuals who are being undiagnosed, who come in with a diagnosis of autism and you undiagnose them, it ranges from like 10 to even 30% in some autism centers or autism clinics. Here there are two studies that I'd like to mention. One we did when Mandy was at Stanford with Simone Levine. She was a graduate student. So what we did, we looked at individuals who were diagnosed in the community with an autism spectrum, and we did a comprehensive evaluation at our clinic, and the number is not very high. So we had 14 kids. But when we did a comprehensive evaluation, 8 out of the 14 ended up receiving a diagnosis of ASD, and 6 out of 14, which is 43%, who did not get the diagnosis. It's a small sample size, but there was recently a paper by Duval who looked at 232 school-age children and adolescents with a pre-existing diagnosis of ASD. They came to participate in the neuroimaging study, and they did a very comprehensive evaluation, and only 47%, that's to 50%, met research diagnostic criteria for ASD. Now, research diagnostic criteria might be a little bit stricter, but still, it's significant difference. So this is as background information. So let's move on to the state of clinical trial in autism and the tragic history from our history, or tragic stories from our history. And I mentioned a little bit secretin, memantine, and the SSRIs. So secretin, I'm glad to see people here because we're used to giving lectures remotely. So who've heard of secretin? If you can raise your hand. Okay, so let's give out a little bit how long you've been in the field. I didn't say age, how long you've been in the field. So, and your level of experience. So at one point, people were so much interested in secretin to treat individuals with autism that secretin was in short supply across the country. And this started with a paper by Hogarth, who's a gastroenterologist, who gives secretin to kids with severe autism. They did an endoscopy, and secretin, you give it to open up a little bit the duodenum when you're doing the endoscopy. And after these endoscopy, he noticed that these kids did get better. And he published that in 1998. And suddenly everyone got interested in it, CBS, CNN, and then it was all over the news. And fast forward a few years later, there was more than 15 randomized control trials looking at secretin in autism. And all of them were negative. So I'm bring up that, and I mention it in terms of that it's important to do randomized control trial, but we have to taper a little bit our enthusiasm. We probably would have benefits maybe from 2, 3, 4 randomized control trial by 15 with all of them negative. So that's unfortunate because we don't have infinite resources. And in the field of autism, as you know, every 6 months, there is something new that people get excited about, and suddenly everyone is using it, whether it's a stem cell transplant or cannabis or CBD. So I think it's important to do the research, but we have to be realistic in terms of how many studies we need to do. This is another study looking at memantine. Memantine is an Alzheimer's drug, is a non-competitive NMDA receptor antagonist used to treat for Alzheimer's disease. And there were 3 case reports, retrospective chart review, showing that maybe it's helpful in the treatment of social deficits in individuals with autism. And Forrest got very excited about this compound, and they did a series of investigations, and including this one, which probably is the largest research study in the field of autism in terms of from a clinical trial point of view. You know, we screened 1,200 people, we enrolled 906, and these individuals were treated openly in this study with memantine. If they improved by 10 points on the social responsiveness scale, they were randomized into a double-blind withdrawal study, either placebo, lower dose, or same dose of memantine. Fast forward to 2019, when we published the study, there were no differences between the 3 groups with regard to benefits from memantine. A big disappointment. But I treated few kids with memantine, and I'm very skeptic, and my threshold to be convinced is very high. And several kids actually did benefit from it. And the way how I convinced myself if they benefit from it is that after the end of the trial, they went and I saw them in my clinic. We'll treat them for 6 months. When summer comes, we'll stop the medication and see what's happening. And within 2 to 3 weeks, you get a phone call from mom. Johnny is not doing as well. Catherine is not doing as well. And we put them back. And I tried that a few times. So that convinced me that there is something there. But look at this like major study, and we didn't see anything. So that's got me thinking in terms of what are we missing. And one of the things that came to mind is the complexity of social areas in the field of autism. And it's naive to think that one drug is going to treat all symptom domains that's related to social deficit. This is a summary of the brain regions and neurotransmitters involved in the social behaviors. You know, look at the brain regions, look at the neurotransmitters, and what we were targeting with memantine is only glutamate. So it's unrealistic to expect that it's gonna help all different social domains. And we start thinking maybe we should look at social abilities in different ways. And one approach that we felt might be reasonable to look at is the RDoC, which, as you all know, identify initial set of basic biologically meaningful dimensions. One of them is social functioning. And the different domains that are in the social processes is affiliation, which is motivation to engage in social interaction, receptive communication, the ability to perceive and interpret social signal, and expressive communications are skills necessary for initiating and maintaining social interaction and relationships. So that got me thinking, maybe memantine was helping one of these domains, and we basically missed the boat by looking at all social domains. This was in many years ago, and that's what led us to the development of the Stanford Social Dimension Scale, and we'll talk a little bit about that in a few minutes. Another domain is a story which is the SSRIs in the treatment of restricted repetitive behavior. There have been like 3 or 4 randomized controlled trials in kids using SSRIs to treat restricted repetitive behaviors. And all these studies in kids are relatively negative. You can stretch 1 or 2 of them to whether they are positive, but I think if you compiled all of them, it's basically a negative story with regard to SSRIs in kids. But this is a very simplistic way to look that maybe SSRIs will treat all restricted repetitive behaviors. So a recent study that we did, we looked at about 16,000 kids on the spectrum, and we did the exploratory structural equation modeling analysis to look at the different domains of restricted repetitive behaviors. And we identified 8 different domains. Now, when you think about it, well, it makes sense. One of them is repetitive motor behaviors. Second one, insistence on sameness, restricted interest, unusual interest, self-injurious behavior, atypical sensory features, obsessions and compulsions, repetitive language. It's possible that the SSRI might be treating 1 or 2 of these domains, but if we're looking at the total of restricted repetitive behavior, whatever change in one of these domains is going to be washed out because they did not improve overall unrestricted repetitive behavior. And that's got us thinking to develop another scale that's more granular, that would look at all of these domains, and I will mention that to you in a few minutes. So when it comes to treating restricted repetitive behavior, what is the evidence? Unfortunately, it's again, second generation antipsychotics. And here you see, this is from the trials with risperidone and Abilify. And it, stereotypy was not a primary outcome measure, but in the secondary outcome measure, you see a change with these medications with regard to the stereotypy or repetitive motor behaviors. And you see the same pattern with risperidone and Abilify. Now, the challenge is that it's unlikely that we're going to use an antipsychotic to treat these behaviors. Occasionally, there is an indication when it's what's associated with severe irritability and aggression. But again, it's kind of a secondary finding. Ideally, there should be the focus of a prospective study to see whether this is the case or not. But if you look at the way how we are prescribing, about 25% of our kids we're prescribing antidepressant, and most of these antidepressants are SSRIs. So we find them to be helpful, but when you look at the research is saying they do not help restricted repetitive behaviors. So probably they are helping with anxiety or helping one of these subdomains. So that's why trying to fine tune a little bit the different domains of restricted repetitive behavior and designing a study that will target specific subdomains, we might be able to see a signal. So where are we now? It's been a costly journey. That's why there is a need for good psychometrics, measures with good psychometric properties. And where we are right now, we've gained insight. And as we all know, we're in the mental health field. Insight is very important. It took us 30, 40 years, but at least right now we can move forward with more informed studies. And one of the things that we learned is that it's unlikely right now we're going to run a study where we include kids with autism, just based on the diagnosis. So it's important to include additional criteria in addition to the diagnosis of autism, and we'll give some specific example with regard to the irritability and the treatment with PRT in targeting language. So the narrower the inclusion criteria, the more likely you're going to see benefits. Also, we became aware that we have to think about using smart trials, developing biomeasures, and using target engagements. And the question these days that we ask ourselves, not whether there will be a response, but more specifically, who will respond, when, and what's the optimal range? You give an intervention, do you treat at age 2, 7, 17, or 27? What specific domain should we target? what dose? Do we give 5 milligram, 10 milligram? Do we give 10 hours of PRT or 20 hours of PRT, and for how long? And why are they responding? What are the cognitive profiles? What are the biologic profiles that will determine response or will help in determining response? So moving on to talk about a little bit about the complexity of the disorder that we are dealing with. So I hope everyone will agree that autism is the most complex neuropsychiatric disorder. I think we put shame a little bit schizophrenia and Alzheimer. Like in Alzheimer, you have maybe one pathway that's involved, or in schizophrenia, maybe 3 or 4. In autism, wherever you look at the brain, there is something abnormal going there. And this is, you illustrate a little bit the complexity of what we're dealing with. We all heard the story of increased brain size in kids with autism. So when you look at kids here, this is by Lange and all, looking at the brain size in autism. We know that when kids are young, on average, kids, they have large brains compared to their typical developing kids. And then over time, there is a change where this difference disappears, and there might be some signal that the brain is smaller in individuals who are adults, the autistic individual who are adults. So it's a very complex story. And to dig a little bit more, give you an example of the cortical thickness, which is a contributor to increase of brain size. This is work that we've done a few years ago, where we found that cortical thickness in individuals with autism is thicker when kids are young. And actually this difference disappears, and there is evidence that maybe in adulthood the cortical thickness is a little bit thinner. So it's like these biologic metrics are changing over time. Now compare that to ADHD. This is the figure here at the bottom on the right hand side. This is cortical thickness in kids with ADHD. They start with a thinner cortex and they continue to be thinner over time. While in autism, you start thicker and you end up probably thinner. So the biology is changing. So when we think about treatment, whether it's behavioral or pharmacologic, the response might be different at age 5 than age 25. And also the side effects might be different at age 5 from 25. So that's a complexity that's very specific to autism that, for example, we don't see it as much in other neuropsychiatric disorder. And that's like a curveball in every study we try to do, whether it's behavioral intervention study or biologic study that we try to do in autistic individuals. Okay. Let's talk about the challenge of heterogeneity. First, I would like to introduce the beast here, which is autism. And you've probably heard that if you've met one kid with autism, you've met one kid with autism, because they are so different. And I tried to illustrate that in the study by Eric Hollander, when they gave oxytocin IV to treat restricted repetitive behaviors. And if you look at the right-hand side with this panel, you see that a wide range of responses, some people getting better, some people getting worse, whether they are on the active or on the placebo. So when you see this, you see, why I am in the field of autism. So we have to start thinking, we should not give up and start thinking a little bit, what can we do to outsmart this? And that's where the insight is helpful. The second part of this slide is to mention this study by Rodgard. It's a European Scandinavian group that looked at temporal changes in effect sizes of studies comparing individuals with and without autism. So basically, they looked at observational studies when they assessed theory of mind or eye contact or executive function over time, let's say in the 70s, 80s, up to date. And what they've noticed is that the difference between the autistic individual and the control is decreasing over time. And they speculate it's because we are including more heterogeneous individuals with autism in the autism sample. And that's why the difference is decreasing over time. And if you look at the trend of the way how we are characterizing individuals with autism these days, the bar is a little bit lower, the threshold is a little bit lower with regard to inclusion-exclusion criteria. And the example that I gave, like 25 years ago, you wouldn't get a grant funded if you don't do ADIR, ADOS, and expert clinical opinion. Right now, we're seeing like grants, we're seeing papers with only the ADIR or the ADOS or the SCQ. So that's going to add heterogeneity to our samples. And to some extent, even though we're recruiting more, we're publishing more, but we're shooting ourselves in the foot by adding heterogeneity to the process. So one approach that we highly recommend and we learn it is looking at narrowing the inclusion-exclusion criteria, and we have examples of positive results. The first one is from risperidone in children with autism and treating irritability. We're all familiar with these studies. We all use risperidone. It does work. Science support our clinical practice. And they had a very narrow inclusion-exclusion criteria where the aberrant behavior checklist irritability subscale had to be 18 and higher. The same approach was used in the aripiprazole studies, and they used ABCI subscale of 18 and higher. And this is the findings. You see both of these studies showed significant improvement with these medications compared to placebo with regard to ABC irritability. So that's the value of a narrow inclusion-exclusion criteria. This is general education about meta-analysis of pharmacologic treatment that we did a few years ago. On the top panel is the summary of all the studies with risperidone and Abilify. And since it's below zero, all of these studies indicating that risperidone and Abilify or aripiprazole are effective in the treatment of irritability. On the left-hand side, we like to include that to show that there are a lot of studies out there that looked at irritability, some of them showing some benefits, some of them did not. But this to encourage people to look at these compounds that have less liability when it comes to side effects and might be worth exploring to target irritability. Two things I'd like to point out. One is Depakote. There is one study that's showing no benefits, another study showing benefits. And the other one is, I'm biased, is N-acetylcysteine. Mendy mentioned that. So, but it's one study. And, we shouldn't base conclusion on only one study. Fortunately, we're doing currently a study trying to replicate this finding in kids with autism in targeting irritability, but also in restricted repetitive behaviors. Let's move on to biologically based subgroups. The first one is narrow criteria. The second part is trying to find subgroups. There is the oxytocin story. This work with Karen Parker, who's an oxytocin and vasopressin biologist. We've been working together for probably 16 years, 17 years since I came to Stanford. We're all familiar with the oxytocin, that it helps with social recognition, enhancing peer recognition. It helps with pair bonding and anxiety, helps with trust, love, and orgasm, and maternal and paternal behaviors. So that's why people use it in neurotypicals and found that it's helpful for the treatment, for improving emotion recognition and enhancing face processing. And it's a no-brainer to consider using it in autism. And there have been multiple studies looking at oxytocin in kids with autism. This is from a few years ago. And unfortunately, the results are all over the place, with most of them negative studies, with maybe one or two measures that will separate from placebo. This is a study in adults, this is a study in children, this is a study in adolescents, and unfortunately, no consistent story, mostly negative. We did one study where we looked at oxytocin in kids with autism. It was published a few years ago. And the interesting result here is that when we compare the active to the placebo, we did not find any differences between the two groups. However, when we controlled for baseline level of oxytocin, that's when we started seeing difference, with individuals with oxytocin responding better, improving better when it comes to social deficits compared to the placebo. So that's very helpful because this is a subgroup that potentially could be responsive to oxytocin. Unfortunately, our story ended with a large trial that looked at oxytocin in a large sample of individuals. Very well designed study. They didn't see any benefits from oxytocin, even when they controlled for baseline plasma oxytocin, which means that for now, this is a negative story with regard to autism. We're all excited about that. And most probably, if you're working with kids with autism, you've had one of the kids that you're working with on oxytocin at some point. So let's look at a cousin of oxytocin, which is vasopressin. When we felt that oxytocin might not be as effective as we would like it to be, so we thought maybe vasopressin will be a good agent. And when you look at its profile, it's actually not bad. It's very similar to oxytocin. It helps with regulating social functioning, especially in males. And we know autism is more prevalent in males than females. When you give vasopressin to neurotypical individual, there is enhancement of memory for happy faces, enhancement of identification of the social world, enhancement of cooperative behaviors. And the joke with Karen Parker is that we should have given this to our kids. Maybe that will increase their cooperation with us. And when you look at human research, there are studies showing that it enhances speech and word formation and improves short-term and long-term memory in individuals with central diabetes insipidus. So that's why we thought, let's give it a try. And the paper is published. Unfortunately, we saw benefits with vasopressin in targeting several symptom domains in individuals with autism. We measured using the social responsiveness scale. We looked at the anxiety and repetitive motor behavior or repetitive behaviors in general. However, more importantly, that benefits became significantly more clinically better when we controlled for baseline level of vasopressin. So it is kind of like the same storyline to look at for a biologically homogeneous group. So we're very excited about this. We got funded to do a larger trial, and we just finished the trial in March, so last month. And we recruited 109 individuals. We randomized 109 individuals, kids between the age of 6 and 17. And to our knowledge, it's the largest single-site psychopharm study in the field of autism to date. So we're entering the data as we speak, with the hope that in the next 3 to 6 months, we will analyze the data. And I joke and I say, if in 1 year you don't hear anything about it, that's probably negative. And if it's positive, you will hear about it on the news. So very good. So let's look a little bit at how we outsmart the placebo response. There are several examples in the field. The first one is a paper that was published or a study that was published by Kathy Lord, when they basically did give the ABC and the SRS to kids who are not receiving any significant treatment, average treatment, 8 weeks apart. And they've noticed that the ABC improved by about 23% or 29%, and the SRS improved by 7%. So look at the variability over time with that. The second study is memantine in children. That's the randomized controlled trial. And as I mentioned earlier, this is a failed trial. Look here at the at baseline, no differences between the two groups. 12 weeks later, actually the placebo group improved as much as the control group, as the active group. So that's something we run into in our clinical trial. We know that in depression it's also very high. So we have to think a little bit how we want to outsmart that. And there are several ways to do that. One is definitely better measures, objective measures. Like right now, we're doing a sleep trials using polysomnography. It's a more biologic, so we have questionnaire, but in addition to that, we have a PSG before and after. The other one is smart designs or complex designs. And this is a very interesting approach, and that's what we used for the vasopressin study. We wanted to, our goal is to do three things. One is to repeat our findings from the small trial that we did. Second is that we wanted to look at 8-week duration of the trial instead of 4 weeks. And the other one is that we want to eliminate the placebo response. So we cannot take credit for this design. It was suggested by Maurizio Fava from Boston. And let me walk you through that because it's very fascinating. So we had 20 kids who received 4 weeks of drugs and another 4 weeks of drugs. 40 kids who received placebo for 4 weeks, then 4 weeks of placebo, so 8 weeks of placebo, 8 weeks of drug. And we have 40 kids who started on placebo for 4 weeks and then shifted to drug after that. And for the green square, so we compare drug to placebo, and this is to replicate a little bit our previous findings. So that's goal number one. The second goal is to see whether we'll get more benefit after 8 weeks of treatment. So that's the yellow square. And the third one is to, if we end up with a high placebo response, we want to get rid of the placebo responders. And this is the yellow group. So here they have placebo. So if they are responder, we exclude them from the analysis and we look at only the people in the placebo and drug. So that's how we can outsmart a little bit some of the designs. The other one is single blind lead in. We're all not something suspicious about that. So one study we completed as an open label study is using pregnenolone, which is the neurosteroid, a GABAergic modulator, trying to target the irritability in kids with autism. And actually it was adults with autism, and we did find a signal. But when we were designing the randomized control trial, we wanted to make sure that we have a single blind lead in. And this is results from the study that's in progress. This is the first 2 weeks change in the ABCI, a significant improvement just with patients being coming to see us and with just the placebo. So that's fortunate because these individuals will be able to account for this variability in our analysis. So that's why finding these will be very important. So let's move to the last part, which is talking about the outcome measures. As I mentioned, that's not my area of expertise, but I realized that if you cannot measure it, you cannot improve it. So measuring is very important. These are different people over the years who said the same thing, and they took credit for it. So one is by Lord Kelvin. Another one, you cannot control it. You cannot control what you cannot measure. If you cannot measure it, you cannot change it. And if you cannot measure it, you cannot manage it. So we came up with one at Stanford, and we said, if you cannot measure it, you cannot treat it. So that's why the focus recently was our group on measure development. That's the social responsiveness scale. We all love to hate it. We don't like it. We see that there are big problems with it. But guess what? Most of our studies, it's our primary outcome measure because it's the best scale available to date for us. So it's a parent questionnaire, 65 items. But when you look at the different items, there are some that are related to social and some other items related to repetitive behaviors. And they've proposed 5 subscales. But when you look at the psychometric properties of these 5 subscales, they are not very good. So if you look at the different items, they don't match well with social awareness, social cognition. So that's why we don't recommend using it. I know John might not be very happy hearing that, but it'll be good to see in terms of any data supporting the psychometric property of the subscale. You can use the scale overall, it's pretty good. But the subdomain that they proposed are not as good as we would like them to be. Tom Fraser did a factor analysis and identified 5 different subdomains that are supported by good statistics: emotion recognition, social avoidance, interpersonal relatedness, incidental plainness, and repetitive motor behaviors. So these are the subdomains that we recommend using. I mentioned earlier about our interest in the RDoC, trying to look at the different subdomains that are related or that are present in the SRS. And we did an exploratory structural equation modeling and confirmatory factor analysis, and we identified 4 different subdomains that will map well on the RDoC, and they are part of the SRS. And one of them is, affiliation, communication, that is the facial and non-facial, and then understanding mental states. So that's important when using the SRS. If you want to look at subdomains that will map onto the RDoC, we recommend using these items, and this paper is published. Now, how that can come handy and how can be helpful? This is a study that we published recently looking at the effect of Lactobacillus reuteri in the treatment of social deficits in individuals with autism. We are talking about the microbiome, how you can manipulate that. The paper was published recently in Cell Host and Microbe, and we did find significant benefits on the SRS with regard to the use of this lactobacillus. But it was not the primary outcome measure. The primary outcome measure was the ADOS, and as you would expect, it's very hard to move the ADOS, but the SRS was one of the secondary outcome measures. This is the total score. You see significant improvement overall. But what symptom domain, what social symptom domain did improve? That's helpful because if we design the next study, we want to narrow a little bit the target behavior. And what we did find is there is improvement in the social communication, but not in social motivation or understanding mental states. So Lactobacillus reuteri might be improving the social domain, but not all social domains, specifically social communications. So based on our interest in the social domains that are based on RDoC, we developed the Stanford Social Dimension Scales. This is work with Mirko Javarik and Jennifer Phillips. And we have 5 different domains right now that are validated. We've done 2-3 studies on that. The first one is social motivation. Second one is social affiliation, expressive social communication, and social reception. And we have a 5th domain. We don't know what is it right now. We're trying to replicate this, which is unusual approach. It has very strong psychometric properties, convergent and divergent validity. It's free. You can download it from the web, and we'll be happy to talk about that at the end. But more importantly, we developed norms, because if you want to include people with some level of social deficit, you want to make sure that you're including individuals who are not functioning very well with regard to, let's say, social motivation or social affiliation, because they have no room to improve. So you want to include individuals who have deficit in these areas so you can treat them. The second study, the second measure that we developed is the dimensional assessment of repetitive behaviors. We looked at the existing measures. They don't have full coverage and good coverage for all the 8 different restricted repetitive behavior domains. So that's why we developed the DARB. We don't like the word DARB, but that's what only we could come up with. And we validated it in like about 1,800 kids. And we have 8 different domains and several items, more than 7 or 8 in each subdomains, because if you're using that in a clinical trial, you want to have a range to be able to improve. And also, we developed normative chart. This is based on kids with autism. while the SSDS, the norms were based on neurotypical kids and neuropsychiatric kids, because we feel the DARB is more appropriate for neurodevelopmental disorder, while the SSDS, it could be used in ADHD, in anxiety, in any disorder where you have suspicions of social deficits. And this is my last slide. I'm in Seattle. I have to mention the ABC CT, which is looking at, it's a multi-site trial, which is using biomeasures to be able to assess change over time. This is very interesting work, and that's what we should be doing more of that. I think the Simon Foundation also put in a similar RFA to look at biologic measures, biometrics. Here, they are looking at EEG 4 paradigms, and in terms of eye tracking, 5 different paradigms, and it looks like they are promising candidate for the EEG and another one for eye tracking. So hopefully additional data will help confirm these so we can use them in clinical trials. I'm sure there's updated information about that and we'll be happy to learn about it. And this, I will end my part and I will introduce Grace to finish our presentation.
All right, so it's my job to finish the story here, to tell you about early intervention, some of the work we've been doing in pivotal response treatment, developmental reciprocity treatment, and some of the social and group-based interventions that we're doing now. So many of you are familiar with pivotal response treatment. This is a naturalistic developmental behavioral intervention that's been around for a number of decades now and is based on principles of applied behavior analysis, as well as integrating developmental models for treatment. And there are, in the sort of basic version of PRT, we teach 6 individually validated components that are designed to enhance motivation for learning. And so in the antecedent, we have 3 critical variables: clear prompts, shared control, and task variation. And in the consequence, we use contingent reinforcement, direct and natural reinforcement, and reinforcing attempts. So I'm going to take you through a little bit of the journey we've been on over the last 15 years or so, starting with your own Mendy Manjarrez. A lot of credit goes to her and Antonio for getting this initial PRT randomized control trial funded through Autism Speaks. We had 53 children with autism and significant language delay. So really important here that we were selecting for a narrow group of young children with autism, 2 to 6 years old, and they were randomized to either a PRT group intervention, which Mendy developed, or a psychoeducation group, so an active control for 12 weeks. And not surprisingly, the group in the blue here, this is the PRT group, did learn to implement PRT over the course of 12 weeks. The group in the parent education group that didn't learn about PRT was not implementing PRT at the end. That's the part that's not surprising. It's actually pretty encouraging that with a group-based intervention, the families still learned PRT with just 90 minutes of treatment once a week over 12 weeks. That hadn't been demonstrated before. And maybe even more interestingly, we saw that significant group differences by 6 weeks and also continuing at 12 weeks in the total number of utterances that the children were making during a structured laboratory observation with their parents. And we've been looking at these data. We're doing a sort of a secondary analysis that's under review right now, looking at both adherence, which is the fidelity of implementation, no group differences at baseline, but significant group differences in the PRT, favoring the PRT group at both 6 and 12 weeks. But also, not only does adherence improve, we're also seeing differences in the frequency of the learning opportunities that the parents are providing. So again, at 6 weeks and stable at 12 weeks, the PRT group the parents in the PRT group seem to be not only implementing the treatment with fidelity, but also delivering more frequent language opportunities. And our good friend, Tom Frazier, was really interested in this and helped us do some structural modeling and also a cross-sectional mediational model to look at what is it that we're seeing, what is the relationship between adherence and frequency of opportunities. And so in the top panel here, what you see is that there's a significant effect of randomization group on, especially the strongest effect is on adherence. So the families that are randomized to the PRT group in this sample really did learn to do PRT, and that's a really strong relationship. If we look at the relationship between PRT learning, the fidelity, adherence, and the learning opportunities, we tested a few different kinds of models. So we tested a parallel mediator model where randomization would affect adherence and opportunities separately and drive improvements in child utterances, and also clinical, expert clinical opinion or judgment about improvement. That's at the bottom. We tested a model where randomization group leads to improvement in learning opportunities and then leads to improvement in adherence. But actually, the model that has the best fit with our data is this one that you see here. There's a significant relationship between the number of learning opportunities and the child's utterances, but learning opportunities seems to really explain, mediate, almost fully mediate the relationship between adherence or fidelity and child utterances. So what does this mean? It means that we need parents to learn how to implement treatment with high quality in order to drive the frequency of the learning opportunities. But frequency of learning opportunities is really the thing that's directly explaining improvement in child utterances. So we really need both, and we're interested in looking at replicating these findings. We did a second randomized controlled trial of PRT, a little bit, again, selecting, we had 48 children with autism, also significant language delay. Here we really specified what that significant language delay needed to look like. So 2 and 3-year-olds had to have more than 1 standard deviation below the mean on the preschool language scale. 4-year-olds more than 2 standard deviations, 5-year-olds more than 3 standard deviations to really get a fairly minimally verbal population of children. They were randomized to either a package treatment or a delayed treatment group. The package included both parent training, but also 10 hours a week of clinician delivered in-home PRT for the first 12 weeks and 5 hours a week for the second 12 weeks. And we had a fairly diverse sample. We saw improvement by week 12 and to some extent sustained at week 24 in the frequency of utterances in a 10-minute structured laboratory observation. I'll show you a quick video here so you can get a sense of what one of the first participants in our trial, what his this looked like when he was practicing PRT with his mom. So. All right, so cute. I think one of the things I love about that is, they were playing with a ball at first, and then can you imagine what would happen if the mom said, like, you can't climb on the furniture. No, you have to play with the ball, right? So it's such a good example of her following his lead. And, they're both in their jammies, and this is just like a regular, Sunday afternoon or whatever. She's getting a workout with picking him up. So a lot of benefits from PRT, but it's, in that study, we actually also tried out using the brief observation of social communication change, a new measure, where we applied the Bosc coding algorithm to look at our structured laboratory observations of parent-child interaction. And we did see a significant decrease in the PRT group in Bosc scores at week 12 and at week 24, indicating improvement in core aspects of autism symptomatology over time during interactions with parents. And this is a really exciting finding because not only were we able to show improvement in that narrow focused, frequency of utterances that we were directly targeting, but now we're seeing improvement in things that are collateral benefits, more social, things like joint attention and social interaction bids. A few of my colleagues have conducted a meta-analysis of pivotal response treatment trials to show that at the meta-analytic level, there is definitely a consensus that there's strong improvement in these targeted language areas like number of utterances, and this is the MacArthur-Bates CDI, so sort of vocabulary. But the jury is still out a little bit on whether across PRT studies we're seeing improvements in global aspects of socialization or adaptive behavior. And some of this relates to some of the measurement issues that you've heard about from Dr. Hardin today. We did do a study in the same trial, the PRTP study. We also tried out using the LENA, Language Environment Analysis System, which is an automated audio recording device that the children wear for an extended period of the day. And with using the kind of out of the box metrics from LENA, we did not see group differences between baseline and week 24 in the conversational turn count. But in partnership with Paul Yoder at Vanderbilt, we were able to use an even more rigorous analysis of reciprocal vocal contingency, which is essentially a 3-part conversational turn instead of a 2-part turn that the LENA device measures. And we did detect differences, significant improvement in the PRT group at week 24 when using that little bit more rigorous measure of conversational turns. There have been a few studies of neuroimaging studies of PRT. Pam Ventola and Kevin Pelfrey published this study a number of years ago showing functional MRI change in an uncontrolled trial of PRT. This is a sort of school age group of verbal children getting PRT. And then our group has published one pilot investigation, again, an uncontrolled trial showing both, so this is structural MRI with little kids during natural sleep, showing that higher baseline volume in the superior temporal sulcus is associated with greater change in vocabulary on the CDI, and also on the far side, on the in the second graph, you can see from diffusion tensor imaging that the greater change in utterances is associated with better quality of the connections in the longitudinal fasciculus. In this small sample pilot trial, we're just in the process of completing a randomized controlled trial of PRT where we're doing structural and DTI imaging. So again, you'll hear about that on CNN if we are able to replicate our findings. I'm going to quickly tell you about a few other trials we've been doing. This one has just been completed and we're writing up the results for publication. This is a trial, a randomized controlled trial of a developmental treatment, not a behavioral intervention. This is really a developmentally based treatment where we randomized 16 children to the DRT group and 19 children ended up in the delayed treatment group. And they got a similar dose of both parent training and in-home therapy to the trial I just told you about. We were able to document that with clinical global impression, so a blinded expert clinician rating of improvement. We had more children in the DRT group showing much improvement and some children showing minimal improvement, but most of the children in the delayed treatment group had either no change or minimal improvement. We also used the social responsiveness scale and did in this trial demonstrate significant group differences by week 24 in improvement in social functioning overall. This is the total T-score. And then using the Uljavarik scale, just the subscale focused on social communication, it appears that it's the social communication subscale that's driving the improvement. There were no benefits on attachment, affiliation, or understanding mental states. And finally, in that trial, we did not see group differences in Vineland or on the CDI vocabulary, suggesting that with this developmentally focused treatment that really does focus really narrowly on social reciprocity, we get better improvement in social functioning, social communication, but not as much improvement in Vineland or in adaptive skills or in vocabulary. We just completed another, this is again a PRT-based social skills intervention, another small randomized controlled trial of a program we called Social Success, which is a group, both parent training intervention and also a social skills group with typically developing children. These are 4 to 6 year olds with verbal IQs over 70. And this paper just came out in JAD, where we were able to show improvement in the treatment group in both prompted behavior regulation initiations. So these children are making more requests to their peers, prompted, and also interestingly, excitingly, unprompted behavior regulation initiation. So it seems that when parents learn how to use behavioral, naturalistic, developmental behavioral principles to facilitate social interaction with peers, the children are making both prompted, but also more importantly, unprompted initiations. We asked parents also to rate the level of initiations that their children were using, and the children in the green here made more improvement by post-treatment. And interestingly, using the Stanford Social Dimensions scale, the social motivations subscale, we were able to show that parent-rated initiation improvement was related to low baseline social motivation. This is really interesting because we usually think that children who have higher skills will perform better, but it looks like maybe a very targeted motivation-focused intervention is especially effective for children who have motivation deficits at baseline, which is really exciting to explore. All right, and the last part of our story here is the Stanford Preschool Autism Lab I want to tell you about. This is a high quality early intervention program for children with autism, really inspired in part by the program that you have here that Dr. Manharas runs, where we can test effective models of early intervention. We actually run our program as a lab where we're running clinical trials and we're testing out interventions. We've been partnering with SRI International to outfit our classrooms with 3D imaging and to be able to use machine learning techniques to detect treatment response. And so we have we have cameras in the corners of the rooms and a 360 camera on the table. We can have a clinician wearing a camera, and then we have ways that gets securely transferred to our partners. This gives you a little bit of a view of our classroom. We can get all sorts of 3D images and are able to track the children's behaviors. We're using this to automatically detect eye contact, smiles, utterances, and imitation. And we're developing automated measures for that. Because if any of you have been involved in some of the studies that I talked about before, you know that a lot of hand coding is involved with these procedures. So here's a little glimpse of how the computer can detect when this kid is smiling. And when it's red, you can see he's not smiling, and then he's gonna get happy and turn to the clinician. And it's not perfect, but by combining it with eye contact and other metrics, we're gonna start to be able to detect things, positive affect in really interesting ways. And interestingly, in a few of the children we've piloted, you can start to see a lot of individual differences over time. So the yellow kids look like they're not improving at all. The green kids look like they are improving. And here's a blue kid who, started off with a lot of smiles to begin with. So we have this program, this clinical program that we run, overseen by a number of BCBAs. We brought our beloved BCBA, Maria Bundang, here with us today. And we're running right now 2 clinical trials, one comparing center-based treatment with delayed treatment group, and one comparing both center-based and in-home treatment versus delayed treatment group. So much of what we've shared with you today, this is Antonio's favorite slides. We threw it in here just for a treat for all of you. Is very preliminary. Don't get too excited, but we're always excited about this. I hope that we've convinced you that doing clinical trials and trying to understand how to do both effective pharmacological treatments and behavioral treatments in autism is complex, but we are making progress with our insight, and looking forward to the next chapter. I'll thank our research team and our funders, and of course the families and children who have so generously participated in this work. And I realize that it's time to end, so I'll pause here and see if we have any time for a couple questions.
We had some great conversation in the chat over Zoom. And I just want to let everyone know that we will save that and make sure that you guys both get a copy of that in case any responses want to happen kind of offline. But before we end today, I just wanted to ask everyone who came, thank you, if there's any questions from the room. I think we have time for maybe one question, and then maybe if anyone wants to stay after to chat. But yeah, Mark.
Anyway, I really enjoyed your description of some of the pitfalls and many years of research and many dollars in this area. And the challenge of a disorder that is so heterogeneous and increasing in prevalence and awareness and false positives while you're trying to really determine, who it works for and when. I guess what I was thinking about though is ways to change the phenotype or to really get, to really see a difference. Are we getting away from etiology? I mean, you're talking a lot about kind of description and pathophysiology and scales, but I mean, where are we with that?
In a short, yes, we're getting a little bit away, because when we look at ADHD, we looked at the ASD. There is a lot of genetic overlap. There are a lot of clinical behavioral overlap, and we've tried the categorical approach, and we've made some progress, but not a lot of progress. So maybe trying a different approach or a combination of approaches might be more efficient and might lead us to identifying effective treatment. In another way, like if someone has deficits in social motivation, whether it's related to ADHD or ASD or another, or part of another disorder, it might not matter if we know the neurobiologic underpinning and we're going after that with a specific agent. So that's a little bit the thinking. So staying away from categorical, moving to dimensional. We've all been as hesitant and resistant in the beginning with the RDoC approach. It might not be a bad idea to try it for the next period of time in combination of categorical, which hopefully we'll get something specific.
Thank you. I think we'll end our formal presentation this morning. Before we go, I just wanted to shout out one thing that came through in the chat, which is that the Alyssa Burnett Center is celebrating its 10-year anniversary, and they're hosting a celebration on the 25th of this month from 6 to 8. So congratulations to ABC, and thank you all for your attendance this morning and for a wonderful presentation.